let's start with Du Bois. Um, first, first, I would like you to go through who Du Bois is, if you haven't already checked about it, if you haven't already known him. He's a he's the first Harvard graduate of African American community. Also, he is the first one who started the race and health studies in the second part of 19th century. Please click the link if you here to see how he established certain things. This is a video that you can click and see who Du Bois is, which kind of movement he established, and etc. Okay, let's go back to our issue. Um, Du Bois' insight about race and health and the study he does shows that the higher level of poor health for blacks was one important indicator of racial inequality in the United States. Um, this has many reasons he speculates about. Until that point, until Du Bois talked about these associations of socioeconomic status of blacks, racial discrimination, and health, and many other issues, the dominant medical paradigm was about racial difference in health. The dominant medical paradigm about the racial difference in health was about the biological differences between racial groups, like the skin color, like which race has more resilience or not biologically, or evolutionary theories. This is a lot of biological and sociobiological determinism, which is very dangerous. Some of you probably knows about eugenics, which is the race science studies. It was after the Darwin's evolutionary theory became so popular in the 19th century. There were a lot of people, because of colonizations, colonialism, and many other things, think that some races are superior than the others, and they started to study on how superior one race from the other in different ways by taking a lot of biased variables, a lot of biased studies about race and health. So this is very, very dangerous. We of course, like if you want to look into types of skin cancer on blacks and Latinos and whites, maybe very, very small portion of it is about the racial difference. But about syphilis, about HIV, about cancer, about many other things, there's no way that the racial difference, biological difference in different races makes sense in terms of variables. So just Du Bois' importance is he is the first one, and he's a sociologist that shifted the picture toward vastly different conditions whites and blacks live in, so their environments and then how they make their living from. Du Bois' study shows that the causes of racial differences in health were multifactorial, multi-layered, and they were nonetheless primarily social, not biological. And the social factors were primarily environmental, so it includes poor sanitation, poor housing, thirsty streets, and a lot of other things about neighborhood quality. I just added this words from Du Bois: a system cannot fail those it was never meant to protect, because of the relevance to the last year's discussions on Black Lives Matter movements, and how systemic the differences and the inequalities are, that we should think about changing the systematic way of thinking and the systems itself and the structure, if we can, in many ways about racial discriminations. And Du Bois is one of the founding fathers of this mental operation, that how we should break all these racial barriers by establishing the Niagara movement. Uh, Watch the video if you haven't done so. So what else Du Bois' studies show? Du Bois reported that black men had poorer health than black women, and that the gender differences in health were larger for blacks than for whites. And he explains the reason. He indicates that although domestic work was the only option for black women, work was more available for black women than for their male counterparts. And in addition to that, the conditions of the work for black women at these houses were more conducive to health than those for black men. So if the black woman goes to a house for cleaning, she still benefits from the good environment, the cleanliness, and also the food that these good neighborhoods have. So, what sociology contributes to race and health studies? First of all, the authors in the article that I sent to you um, shows that it is an understudied subject in sociology. There are only 18 relevant articles published by the year 1989, 10 in American Journal of Sociology, and 8 in American Sociological Review. These are the top journals who were published and read by far the most. So it shows something about what sociology is as well. Sorry. And still, we still want to talk about there must be something the sociologists contribute to these discussions. One of the things they did is gathering data about race and health and men and women and differences of health. So if you see here the differences in changes in every 10 years between white men, black men, and the difference between white and black men, and white woman, black woman, and the difference between black woman and white woman, you can see, and this is life expectancy only, this is the most basic health variable you can see how different it is and in which way there is difference. And there are certain times that it is more, like 1950s, the difference between white and black women are huge. Like 1970s, the difference between white and black men is huge in terms of life expectancy. So there are many other things you can see from those. Race gap in health status continues. Of course, it is not only historical. So there are very recent studies which shows in 2006 white men still lived 6 years longer than African American men, and white women had a 4-year advantage over their black peers. Also, of the 4 race gender groups considered, black women have had the largest absolute gains in life expectancy between 1950 and 2006. Again, it can be related to their occupations, their availability of jobs, and etc. There are other studies which reveal that African Americans and American Indians have higher age-specific death rates than whites from birth through retirement. Also, Hispanics or Latinos have elevated rates of some leading causes of death, such as diabetes, hypertension, liver cirrhosis, and homicide. Moreover, the elevated rates of disease and death for minorities compared to whites reflect the earlier onset of illness, greater severity of disease, and poorer survival. These studies only show us that there are multi-layers that we should think about, which diseases that certain communities can have, which and according to what, like, is it because of their occupation, is it because of their nutrition habits, is it because of their neighborhood and environmental hazards, or is it because those populations are just prone to those kind of illnesses because of stress of being a minority, because maybe they are immigrants. So there are a lot of things that we should think about when it comes to race and health. And there are other things that they might be important, such as the duration of or the severity of the illnesses. So one of the studies showed that although blacks have lower current and lifetime rates of major depression than whites, the cases of depression among blacks were more likely to be persistent, severe, disabling, and untreated. So it is the severity and the persistence of the disease rather than the rates of the disease that can matter sometimes for some reason. So one of the contributions of the sociology is to discuss what is race and to go beyond these biological determinant arguments of what race is. So race is in large part as social rather than a biological category. Many sociologists talk about, and actually it's not only sociologists, it's also social scientists, anthropologists, historians, philosophers. So, what do you think about this statement first? And there are many people whom I know, some of my close friends, also black friends, they talk about that it is also a color category, that the color you have seen on the street, many black people who were shot to death on the streets were because they look black. And that's not because their skin color is black. It's not because that's that's a social category. So what we can think about here is actually racial classification systems are the ones that are arbitrary. Race can be still related to color and the biological skin color and many other things, but the racism and the racial classification systems, even when we talk about like there are some categories we talk about all the time when it comes to race and health, especially statistical studies, and that's like black, African American. I saw studies who had like blacks, Latinos, white Caucasian, and some include Middle Eastern as a race, some include Muslim as a race. There are many things that you can think about. Some goes to ethnicities and to show where the origins are from, like Cubans, Irish, whatever you think of. But at the end of the day, these classification systems are very arbitrary and evolved from certain systems of stratification, certain systems of power and ideology. If you think about our first week's lectures and then biopower and Foucauldian understanding of power and ideology that we talk about, you can actually go back to race again and think about the biopower that the race can have, racial discrimination and racial relationships between communities. And it's also an individual issue because we all have different races, and some for some studies it's black people are more comfortable among black people. For some studies it's only regional, and then it's really complex and multiple layered. So um, this discussion of race in sociology brings these questions up on the front. One of them is a matter of biological differences. As I said, it was before the very dominant discussion in medical communities were that race is a different biological category rather than a social issue. So this was actually excluding social origins of diseases, in a way that, like, if you just think in a study that the race is a biological category, then you just check the biological variables. You don't look into which neighborhood the black population lives, or the Latino population lives, or Arabic community lives, or which kind of jobs they go into more as a pattern, and which social structures and which policies, like the actual discriminatory policies, are at play that is affecting their health status. Um, Basically, these research on racial differences in health should seek to understand how social exposures combine with biology to affect the social distribution of disease. So we go back to Paul Farmer, our biosocial approach, and how biology is very intertwined with society and social factors. So without thinking of social origins, social structures, social determinants of health, it is very difficult to talk about race and racial inequalities in health. This is what sociologists contribute. The other discussion is a very philosophical one. Actually, it's almost metaphysical. There is a lot of discussion about nature versus nurture. So it is your nature or your DNA who defines you as a person, or it's your environment or nurture, how you were raised up, how you were socially affected by people. The gene versus environment thing is something like that. It is actually a false bifurcation that is discussed by that has been discussed by sociologists a lot. And We can think about many researches, but research indicates that even in the case of single gene disorders, the severity and timing of genetic expression are affected by environmental triggers, and that established genetic risks can be exacerbated or become protective in the presence of specific environmental exposures. So even geneticists talk about sociological social factors when they were thinking about the severity and timing of genetic expression. So it's not one way or the other. It's both in many ways, and recent sociological research illustrates how gene-environment interactions can potentially shed light on the mechanisms linking the social environment to disease. So it may even make improvements in the medicine as a discipline. Um, Also, another research reveals that exposure to risk factors and resources in the social environment can produce changes in gene expression. I know from my mother is a kindergarten teacher. She has a lot of autistic kids in the kindergarten, and how they are triggered, she understands very well, is actually mostly because of social environment, the family that they grew up in, the nutrition they have, and etc. Although we don't know the reasons for autism, I'm just thinking of my mom's experience. Anyway, so that gene and environment discussion, the social environment discussion, brings us again to social determinants of health, the social structure, social stratification discussions in sociology. The social structure refers to enduring patterns of social life that shape an individual's attitudes and beliefs, behaviors and actions, and material and psychological resources. Social structure is a very vague term, but when you go into what's going on in, as we were going through until now, like global exploitation regimes, the patriarchy, how gender plays a role, how class plays a role, things like this, like big structures. These are enduring patterns that happens to individuals, but it is also a bit more macro than what individual experiences. And many individuals, just because they are in these categories, they suffer or they go through similar experiences and patterns. That's why social structures are very important. And in a seminal study in the 1840s, and Du Bois lived just after that, Engels, which is actually somewhat brotherly to Marx, they write a lot together, showed how life expectancy in Liverpool, England, varied by the occupation of the residents. This is going back to our third week discussion about the occupational health, and these were not new studies. Even in 1840s, there are a lot of studies showing that there is a difference between life expectancy among workers and other occupations. So, SES, which is socioeconomic status, and race intersections on health status are also shown in many studies. One of the studies is here, using the National Longitudinal Mortality Study from 1988 to 1998. The years of life expectancy at age 25 in the United States, you can see the difference between different race, um, so and how it is different by education. One of the variables the authors take for socioeconomic status is education, and some of you wrote on your comments very persistently that education matters in health status. This is a study that shows that it matters in one way or another, um, but also it shows that that blacks and some other racial minorities have lower income at every level of education. So despite education level differences, blacks have still lower income. So race still matters, even education and socioeconomic status are related. So less wealth, net assets at every level of income, blacks have. Blacks have higher rates of unemployment at all levels of education compared to whites. Blacks and other racial minorities, I'm sorry, it was all black and other racial minorities. So racial minorities, let's say, racial minorities have higher exposure to occupational hazards, even after adjusting for job experience and education. And racial minorities have less purchasing power because of higher cost of goods and services in their residential context, according to this study. One other shocking thing is their income. For every dollar of wealth that white individuals have, blacks have 9 cents and Hispanics have 12 cents. If we think about the differences in global hierarchies and global exploitation. We talked about um, how how garment workers make money in India compared to what we have in United States. Here we can see what is different within United States, and it is shocking that blacks have 9 cents and Hispanics have 12 cents compared to every $1 to a white person does. And when you look at the global hierarchies, the blacks in the United States can be the least making money ones, but the garment workers in India and Bangladesh are very, 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 very down in the ladder after blacks in the United States. So these are all complex inequalities that you keep in mind, and intersectionalities, I hope. So, racism and health, also related to neighborhood quality and community conditions, of course. The urban sociologists think about these health issues sometimes, and sometimes they intersect race and health. The role of residential racial segregation as a primary institutional mechanism of racism and a fundamental cause of racial disparities in health. They look into many studies. And an examination of the 171 largest US cities found that the worst urban context in which white individuals lived was better than the average context of black neighborhoods. So what is better and worse is the health status and also the quality of life, like how close to the communities are to good nutrition, to clean environment, to clean sanitation, and clean water, a lot of these things. So how racial segregation in neighborhoods can play a role. This study shows, first, the segregation restricts socioeconomic status attainment by limiting access to quality elementary and high school education, preparation for higher education, and job opportunities. Second, the residential conditions of concentrated poverty and social disorder created by segregation make it difficult for residents to eat nutritiously, exercise regularly, and avoid advertising for tobacco and alcohol. Third, the concentration of poverty can lead to exposure to elevated levels of financial stress and hardship, as well as other chronic and acute stressors at the individual, household, and neighborhood levels. Fourth, the weakened community and neighborhood infrastructure in segregated areas can also adversely affect interpersonal relationships and trust among neighbors. Fifth, the institutional neglect and disinvestment in poor segregated communities contributes to increased exposure to environmental toxins, poor quality housing, and criminal victimization. Sixth, segregation adversely affects both access to care and the quality of care. So you can see a lot of things play factors. I gave some examples before, but these things are listed here. So after these lists of urban segregation or segregation in neighborhoods and how they affected the race and health association, the other thing that I would like you to focus on is at the individual level, experiences of discrimination have been shown to be a source of stress that adversely affect health. I can give my own father as an example. He had a heart spasm last summer because of all the work he did, and he was 55, and the bad nutrition as well, but also the amount of stress that it comes from the loans, the debt that he couldn't pay for his living. So the stress is a very important factor in our health status. Researchers also documented elevated levels of exposure to both chronic and acute measures of discrimination for socially stigmatized racial and immigrant groups in the United States, Europe, Africa, Australia, and New Zealand, as Williams and Mohammed did in 2009. The other aspect that is emphasized in the previous slide is the immigration status. As many of you know, the United States is kind of national pride to be an immigrant country. So in the 2000 U.S. Census data, it shows that 67% of Asians and 40% of Latinas were foreign-born. So there are a lot of first generation and second generation migrants in the United States. Some of them are citizens, some of them are not. If you came to the United States late with unskilled labor, it's difficult to gain, blah, blah, blah. There's a lot of things that you can know about citizenship law better than I do. But if you were born in the United States, then you are automatically a U.S. citizen. So national data reveal that immigrants of all racial groups have lower rates of adult and infant mortality than their native-born counterparts. So the mortality, adult and infant, is an issue when it's compared with the native-born. Also, there's a well-known paradox called the Hispanic paradox, which you read in the article. Although their socioeconomic status is much lower, the Latino communities, their mental health status is much better than the whites. And this is a paradox because mostly we think that if you have lower social economic status, you have worse mental health. The scholars are trying to understand why. There are a lot of sociologists, including one of my close friends, who work on this paradox. Try to understand why. What is it? Is it the social support networks? Is it the religion? Is it something else that plays a role in those communities that will make them less prone to having worse mental health status? So what you see in the migration and health relations that it is very complex and it is very context dependent. It depends on the neighborhoods, it depends on the country, it depends on which migrants, where you come from, what is the source of your origin or your citizenship. Also your skill, if you're a skilled or unskilled worker, if you came from the war zone or from somewhere else. So it's a very, very complex story. The only thing is, like, health is not primarily driven by medical care, but by other social contextual factors that we should keep in mind in all these health immigration association. So medical care is part of it, and the services they receive, the facilities they could and they can't receive in terms of immigrants coverage. But there are other social contextual factors and socio-historical factors that plays a role here. So what can we offer or think about in terms of policies, conclusions and interventions about all these details of race and health relations? First of all, some of these studies from sociology shows that there are some data on certain issues, but there are not some data on many issues. So there's a lack of data for many issues. And how the data is collected is very important in those terms. For over 100 years, the US public health system has routinely reported national health data by race. And instructively, although socioeconomic status differences in health are typically larger than racial ones, health status differences by SES are seldom reported, and only very rarely are data on health status presented by race and SES simultaneously. So we have to look at the intersections of what's going on in between race and SES that may have an impact on health status of people from those communities. Moreover, striking differences are also evident by sex. So we should also check for women, and when some of you did it in your second week blog post to understand the gender differences and sex differences, which makes sense to understand the intersectionality within minority groups. Also, it's complexify the pictures. All these studies in sociology complexify the pictures between race and socioeconomic status. Socioeconomic status being education, social status, occupation, many things that you can think of in terms of bringing your status higher or lower. And also, many of those studies say that fighting against racism and racial inequalities will improve health status of racial minority groups, because even among the doctors, the medical professionals, the racism may affect the healthcare services, but also the health status of people will be very much affected by the racism that they were suffering from, especially mentally. But also in terms of healthcare delivery, there may be some inequalities going on against certain racial groups. Policies are needed that improve the health of vulnerable social groups more rapidly than that of the rest of the population, so that health gaps can be narrowed. So race gaps is matching with health gaps here. We have to find a way to solve these things. I don't want to sound like chicken egg issue, so which affects which, the racial inequalities affecting health inequalities. It can be vice versa too, with certain stigmas, but still, like women have depression, if you say, as a prejudice or as an idiotic judgment without any data, then you actually contribute to those gaps in gender inequalities as well. So what else these studies can bring into light as an intervention to race and health relationships? The actually the policymakers can improve the restructured land use and zoning policies that reduce the concentration of environmental risks. So, for example, close proximity of bus depots to schools or daycares, or not putting any minority groups close to environmentally dangerous factories, things like this. The second thing is public transportation options that encourage physical activity and minimize pollution risks. If you think about especially the rapidly growing nation states such as China, India, the air pollution is a big issue, and thinking of public transportation options is really changing the quality of life. The third one is the creation of public green spaces that promote walking, exercise, and community cohesion. This is a bit of a to be honest, first world problem, but still, it makes a lot of sense to keep the public parks, to keep the public green spaces, and to have a culture of exercise and physical activity. I think one of you had physical activity in the variables of the second blog post. I appreciate it. It makes a lot of sense to think about, especially obesity with physical activities. Anyway. And the fourth thing is educational initiatives aimed at equalizing access to K-12 education and higher education, improving teacher quality, raising graduation rates, and reducing the achievement gap. To be honest, this is not a list that is sufficient. These are only few necessary steps that the interventions should be made for improving health equality among racial groups. So there are many other things that you can think of, and please write down if you think of any interventions, policies, conclusions that you think that will help improving the racial inequalities in health. So these are showing us that there is a holistic picture, that we should think about all the different dimensions of socioeconomic status, social determinants of health, the racial inequalities that may have an impact on health inequalities, and structural violence that has happened to certain groups of people in different places. The examples I gave also is certain medical inequalities that has happened to those groups, those minorities, or those racial groups, just because they belong to those racial groups and they were dehumanized by certain governmental institutions. One of them was the Tuskegee syphilis study. If you don't know what it is, please watch the video now. And see, it's like, please watch the first 5 minutes, because after 5 minutes it's not relevant to what we think and talk here. So some people say Tuskegee syphilis study is one of the most important reasons why many African Americans distrust the institutions of medicine and public health. It is basically in 1930s in Alabama, Tuskegee. They made a study on black people only, because they said syphilis has a different impact on black people, and we want to find some we want to do some research on finding some medicine for black people separately, which is found out that it wasn't true. They were giving people syphilis, injecting it, and they were making the study on them, and there's no difference between black and white people populations in terms of syphilis medication or syphilis symptoms. So in 1991, the Clinton government actually apologized from African American populations about this. But before Tuskegee syphilis study, there were a lot of mistrust going on in broader socio-historical schemes. Um, so actually, many people argue that those broader socio-historical structures, the colonial history of the region and the world actually, that have these racial hierarchies ingrained in them, resulting to these racist biomedical issues in histories of powerful countries especially, but it's not limited to powerful countries. It's racism is actually prevalent almost everywhere. To be honest, when you see racism as a problem that can be fixed easily, it is not possible. We don't want to get cynical, of course, about it. We want to talk to people. We want to change our minds. We want to actually ask ourselves, well, why I feel in this way or that way towards these people who are from different races, or think about race as a socially constructed category and other things. Um, but also there is a limit to fixing certain problems related to the racism, and it is a very, very long struggle that everyone has a role, everyone has to do something, and the post-racial society unfortunately is not happening, so we have to continue doing these fights, personal and social fights. So if you haven't already watched, so I put it here as well. This one is about the Tuskegee syphilis study. This one is about a recent one that is shed light on the Guatemalan one. I gave examples from United States because we live in and we study in United States, but there are many other examples. Very recently, I think in 2013. The Haaretz, Israeli newspaper, announced that with Guardian, a British newspaper, they announced that the Israeli government is using injections of sterilization on Ethiopian women who migrate to Israel for them not to give birth in their countries. And a lot of other racist practices happens everywhere, and it's not only United States or Israel or any other states. This medicine is very much related to race in many ways, and medical histories are very much related to health as well. Who carries disease, um, which kind of social origins, that the poverty, the cleanliness, all these hygiene issues, and etc. Which diseases are in which part of the world, which are not there. So these are all relevant questions we should keep in mind.